Hello, everybody. Welcome to another edition of RevHC's Under the Codes, conversations with healthcare leaders and innovation and thought. We're very lucky today. We have an opportunity to speak with Stu Clark, the CEO of Premise Health, which is the nation's largest employer health provider across the country. Thank you very much for being here, sir.
Oh, my pleasure, Wes. Thanks for having me.
Yes, sir. So you're in a little bit of a unique industry, certainly one that is very well spoken about and the hot topic of the town. Let me go from the top down here and ask, how do you define employer health care? And then on a macro level, what are the advantages and what are the disadvantages of the market as a whole?
Well, our market, like you said, is a bit of a niche market. We provide on-site, near-site, and virtual advanced primary care, and I'll define that in a moment, to the country's largest employers. So if you think about all the high-tech companies, auto, banks, manufacturing, service industries, we now offer physical bricks and mortar advanced primary care sites at over 900 locations, 49 states. And so the gist of our model is that if you provide easy access to high quality primary care and really leverage that primary care provider to the full extent of his or her training, you ultimately make the patient healthier, which means they spend less money downstream with specialists and in the hospitals. So we're in the primary care business, but we have an inordinate impact on the total cost of care. And that's our value proposition.
Wonderful. And I'd be remiss if I didn't start off and say, what's the business's net promoter score? Because I know this is a standout.
Yeah, I think the latest on a sample size of over 300,000 is in the high 80s. We might even have touched 90 at this point, which, as you know, in healthcare is unheard of. Healthcare lives in the high 20s, low 30s NPS. In some cases, certain sectors in healthcare live in the negative NPS. So yeah, our members, our patients love us.
Yeah, I would imagine. It almost seems like the members and the employees are probably your best sales force in the market across the country to help you.
For sure. It's word of mouth is really important. If you think about an employer in rural Nebraska, and we stand up an advanced primary care center and pharmacy for that employer. Once one employee or one family member has a great experience, meaning no wait time, great bedside manner, great follow-up, word spreads very quickly. And next thing we know, we've got the majority of that employer's covered lives utilizing.
As I've heard you mention in other forums, employers have become the largest buyer of healthcare throughout the country and historically don't have a lot of leverage when it comes to cost or even quality of care, et cetera. In partnership with you, how that leverage might change? Like, do you believe employers today actually have more leverage in healthcare in general with you by their side?
I love this question. And what I try to anchor people back to, Wes, is that there are only 4 payers in this country. 4. The taxpayer, the employer, the Taft-Hartley Union Fund, and the family. That's it. The payers, BUCA, have risk in some cases, but only for a year. If the hospitals don't like the rates that they're getting paid by the health plan, they simply renegotiate the next year. And guess where that cost trickles to? The employer, the taxpayer, or the family. So your question is, do employers have leverage? They have all the leverage in the world, but for some reason, they have never fully exerted the influence that they have in the ecosystem. That is changing. Premise is helping to change that. But they're the largest payer of healthcare out of $5 trillion in this country, and they're sitting up in the peanut gallery. We're bringing them down to the front row where they should be because they're the ones paying all the bills.
And do you think that gap has been just a paradigm of thought issue? They haven't thought about being that influential. Has it been they're fractured and they're all over, or that they just don't know how to play the game? Why is that historically?
There are probably a lot of reasons. I think the reason that it is changing is because it is now an earnings per share issue. The cost of healthcare to the Fortune 1000 employers is now an EPS issue. And never before was the cost of healthcare, the cost of coverage to the families, so great that it actually hit the earnings. But it's now $25,000 a year, $25,000 a year for a company to underwrite the cost of healthcare for one family. It's unaffordable to the employer, it's unaffordable to the family. And so things are going to change.
Wonderful. So looking at that, how do you look at your employer partners and how do they define success? Is it cost reduction? I mean, you made a great point. When the CFO is reporting on a quarterly earnings statement across the entire country, health insurance spend, essentially, or cost of health spend, that game has changed. So how are you helping them define success? Is it cost reduction? Is it employee retention?
Yeah. At the end of the day, I think, one, there's no access to primary care in this country, and it's hard enough to get into a specialist. So success means creating great access. So same day appointment or next day appointment, no waiting time, helping that patient get to the right location when they need to be referred. Those are qualitative success measures, but because the healthcare costs are so closely being scrutinized by CFO and CEO right now, there has to be a quantitative ROI, or you're not going to retain the relationship. And so specifically, you look at the claims spend of the attributed population to premise versus the claims spend of the population at that same employer not attributed to premise. And there's a spread. And there's a big spread, specifically about $8,000 per year less spending for our families attributed to us versus the non-attributed families. That is net of our cost of operations. And so the ROI to our customers is substantial. This is all validated. We had a Milliman study. We've got a recurring study with Milliman. I think we're on our third version now. And the savings is profound.
Well, I want to pull on that a little bit because that needs to be a heavy hit. To reiterate, $8,000 delta in a family under your care model, still using commercial payers on the outside or the self-insured on the administrator side,
correct,
versus a full risk type product outside of that delta, that cost savings delta. And I feel like a lot of readmission risk in healthcare or a lot of adherence really comes down to people not wanting to or not paying attention or not caring. Yeah. So may I ask, does that net promoter score contribute to that 8,000? Meaning, in my mind, I'm thinking, I'm actually willing to see my provider.
Yeah.
I'm actually willing to respond to their advice if I like them.
Yeah, that's exactly right. If our members had bad experiences with us, they couldn't get in, or they didn't feel like our providers were paying attention to them when they're in the encounter room, then of course they're less likely to come back. In our model, and this is important to understand, people don't understand this about how we get paid. We don't bill health plans, and we don't bill the government, and we don't bill the family. We bill the employer. The employer pays us every month to run health centers. So if we see one patient or 500, our costs are reimbursed with a fee by the employer. Now, if we don't see lots of folks and create lots of savings, we're going to get fired. So yes, we are very incentivized to make sure that member population is very happy with our services and wants to come back in. We like frequent flyers. It's no additional cost to the employer or the family, but the more they come in, the more preventive care we can provide, the more likely we're able to uncover chronic conditions that are not expensive yet, that are going to get expensive if untreated.
Mm-hmm. Wonderful. So this has to present a risk in the market to a population that has felt like they had no risk, i.e. the payers. In many ways, you said adjacent to them or even in front of them. How are the payers thinking about premise? How are payers thinking about this market? I mean, is it fear? Is it anger? Is it an afterthought?
We're disgracefully, we spend $5 trillion a year in this country on healthcare. $5 trillion. And so when you look at premise as a $2 billion entity, we're just, again, kind of a rounding error in the larger ecosystem. So I think it was Gandhi who said, first they ignore you, then they laugh at you, then they fight you, and then you win. So to answer your question, the payers right now are somewhere between ignoring us and laughing at us. I'm looking forward to the next 2 chapters.
Oh, wonderful. I like that. It doesn't feel like you're scared for that fight. Where do you see an opportunity for collaboration with those payers, or is it going to be adversarial? And is there a subset of those payers, the TPAs maybe, are not outside of the BUCAs? How is there collaboration, or otherwise relationships?
Look, we would love to collaborate with the big health plans and are certainly willing to. The requirement is that we have to have alignment, meaning we have to be aligned with the payer, which is, in our case, the employer, the Taft-Hartley Union Fund, or the family, or all 3. So we have to be aligned with them. And the health plan would have to be aligned also with us, meaning our providers are going to spend as much time as they need to in the encounter room. They are not on a volume-based, fee-based model. Our docs, our nurses, our providers, all of them spend as much time as it is required to address what is in front of them in that encounter room. If we can find a health plan partner that can align with the employer, the family, and premise, not to mention the patient, all day long, we'll work with them. But right now, the typical BUCA model is misaligned, and it is so misaligned that it's untenable at the moment for premise to work with them. I'm optimistic. I think they'll come around because the employer market is going to force them to. And so I look forward to when they do.
So if you're the CEO of one of the BUCA entities, what most concerns them about your emergence, and what are they looking in the rearview mirror?
Well, probably for a longer discussion, Premise has rolled out the Premise Preferred Health Plan. We are in the health plan business. Now, these are pilots, and they are only at 2 employers right now. But at one employer, we've been operating for 3 years, and at the other one, this is our first year. We know we're getting better outcomes. We're sitting right next to 2 different BUCAs at each of those, okay? And the attribution, the enrollment rates are higher for Premise than they are for the BUCA that we sit next to. That's 1. 2, our outcomes are better. So they're still ignoring us. But if you scale that, if you scale the Premise Preferred Health Plan, which we are intent on doing over the next 5 to 7 years, we're going to get their attention. What's going to happen when we end up with 30 or 50% of their population across half of the Fortune 1000? I think we'll have their attention at that point.
I think it will too. I mean, that's got to be their best customer demographic. And to your point, not only are you winning with a better product in the market, but they're doing everything they can to push them towards you.
Well,
meaning from a patient or a customer experience perspective.
Yeah, and look, the problem, again, there are many problems with our system, but one of the big problems is there's no primary care. And so patients are on their own. I mean, move to a city and see how long it takes you to get a primary care doc. Or even if you have a primary care doc here in Nashville and you want to go see him or her quickly because you've got an acute situation going on, get in line. You're probably not going to get in. And so what happens? You use your phone and you use a cute little navigation point solution that your employer gave you. It's so confusing and you end up at the wrong doc at the wrong hospital and you get a bad outcome. That's what's going on right now. We're leaving it to the patient to try to navigate this system, and that's impossible. They're not going to get to the right place at the right time, and they're not going to get the right outcome. And so again, part of our advanced primary care model is not just delivering family medicine, but we're actually providing care navigation. We know where the high quality docs are at the low cost facilities, what we call green on green. So when we refer West Pass to an orthopedist, we're referring you to green on green, the best orthopedist at the most effective, cost-effective facility, meaning we're not going to refer to a teaching hospital. And we're not going to refer just to any orthopedist in that big group. We're going to refer to a very specific subset of those orthopedists cutting at an ASC. That's what we call green on green, and that will get Wes the best outcome.
So I love that. And there's a lot of companies that I have heard that speak about, oh, we have the ability to refer to the best in class, et cetera. I question that a little bit because they're using third-party data.
Yeah.
They're throwing darts against the wall,
Yeah.
et cetera. Can you explain a little bit? Love that model. How do you identify the green on green?
Yeah.
Is that your data? Is that over time? Is that interviews? Is that diligence?
We have multiple data sources, national data sources, but we also spend a lot of time understanding what's going on in that specific community. So it's a combination. It's all data-driven, though. Remember, we are not burdened with the politics in a community of what happens when we include one group versus excluding another. If you're Buca, you almost have to include everybody. We have the luxury of saying, you're going to get 100% of our customers' market share, but here are the rules of the road. You got to maintain an NPS of X. You've got to have certain quality metrics, and let's pick on HEDIS or readmittance or length of stay. Pick your quantitative metric. And we set the rules of the road, and then they get the market share, usually of the largest employer in town. But we don't have to play the local politics. We're going to send to the best folks at the best facility in town, period. That's why we get the outcomes we get.
Wonderful. Wonderful. Let me shift a little bit. Let's talk about what it takes to run this business. This is a very different model. I think on the surface, it sounds like, oh, well, you provide care on site for this population and then you do referrals. What are the challenges that you face? Clearly, this is a competitive environment. These businesses that you speak with are for-profit entities, largely. They're used to negotiating, et cetera. What are some of the complications it takes in running this new and different and innovative model?
You know, we sometimes, Wes, joke around here that we have Stockholm syndrome. And what I mean by that is this is a really hard business. And the reason I say that is because, you know, look at our customer list. It's the banks, it's the high-tech companies, it's the autos. It's the best brands in the world. And we're very proud of that. But guess what comes along with that? Those employers are very proud of their cultures and their brands, understandably. So when you drop 15 health centers across 4 time zones into a Fortune 10 company, you better believe that part of their culture is going to be imprinted on that health center. And they don't care what's working at a competitor necessarily. They want what they want, and they want it now. And so we joke, if you've seen one of these, you've seen one. Now that doesn't mean we have 950 different looking, different operating health centers. Of course not. But our customers' brands are so strong that when you see their health centers kind of reflect who they are. Bass Pro, great example. Bass Pro is a wonderful employer. But guess what? Our health center looks like a Bass Pro store. It's awesome. I mean, it's one of my favorite places. But you can imagine, so extrapolate that across all the different customers that we have. There's a bit of a unique feel and look to each of them. Now, the practice of medicine, the practice of nursing, the practice of pharmacy, that is standard. It's evidence-based. It is measurable. And of course, we manage that very, very tightly. But when it comes to the environment, the culture inside of these health centers, you know, we tend to blend in with the very strong personalities of our customer. So this is hard. You know, any large company at scale wants to standardize. And so we can standardize a lot of what we do, but you still have to have this flexibility to meet that very strong personality, if you will, where they are.
Yeah. Tough customer base, but very rewarding when you're
we've learned a ton from our customers. I mean, where in the world would this company be if we didn't have the customers that we have? I mean, we owe every attribute of premise that we have to our customer base and what we've learned from them over the last 35 years.
So speaking to that and speaking to the personalities of these customers, return on investment is got to be conversation starting point one. How do you get in there? I mean, we spoke about the 8,000 earlier. I mean, that's got to be a great lead. So what are all the metrics? There has to be retention. There has to be, you know, all sorts of things.
Yeah. There is no doubt that our customers tend to be the employers of choice in their areas, whether it's Manhattan or, you know, Fremont, Nebraska. Our customers are usually the largest most sought after places of employment. Where there are multiple employers in those locations, again, whether it's Manhattan or rural Texas, something like a health center offering is a differentiator. It tends to tip the balance in talent acquisition to that employer if they have a benefit like this. And then, of course, once that employee and their family start to use our services, that is one more reason they won't leave that employer. It's not, they have a better job somewhere else and get a promotion. Sure, they're going to leave, but all things considered, they're going to stay where they have easy access to a health center and pharmacy. But, I think that at the end of the day, most employers truly believe that if you take care of your employees, you're going to have a more productive workforce, you're going to have less turnover, and you're going to have a more profitable business. I mean, that's the name of the game in capitalism. And so the selfish side of it on the employer side is that they get better retention, they get better talent, and they have lower costs. But it's usually a combination of the qualitative and quantitative. I can't think of a single customer we have who says, the only thing I want to do is save costs and I don't care about the customer service. For the most part, employers want to take care of their folks. And this program plays right into that.
Totally understandable. I imagine there's also some added subsector benefits, such as, I know you have some defense contractors. Mm-hmm. There's got to be a security advantage to not having people walking in and out all day long and staying within the walls of their facility, or manufacturing where the employee goes downstairs for PT and as opposed to leaving for 3 or 4 hours. Yeah. And those are recognized and those are considered, I would assume. Yeah, for sure. And, we do have most of the defense contractors and we have pharma. And so, these are very highly secure areas. Oftentimes they will have a center or centers on the fence line. So employees can access it from the secured area, families can access it from, the community. More often than not, the health center is in the community for the family, and then there's a health center inside the secure area. It just depends on the employer and the community they're in, the access to care in that community, and what they're willing to invest in. And by the way, I will say this, in today's economy, I would say almost every single one of our customers is humming right now. I mean, people like to talk about defense, but I mean, entertainment, booming, high tech, booming. You saw the bank earnings this morning. Almost every bank beat this morning. Some are having their best quarters in decades. So right now, the U.S. employer is humming. And so they are focused on not retrenchment or contraction, but what can we do to improve efficiencies? And reducing healthcare costs is a pretty darn important lever to pull. Will you speak a little bit about the customization you see client by client? I would imagine physical therapy has a different priority with some employers than women's health, et cetera. Yeah. And you approach it willing as a Swiss Army knife to do almost anything they need. Yeah. Correct?
Yeah, within reason. And as long as there is good evidence-based practice and protocol. We do draw the line with certain experimental things. For example, the easy example is California. We offer chiropractic because, acupuncture. We do offer chiropractic, but acupuncture. We have several customers in California came to us years ago, said, we really want acupuncture. Well, we investigated it. We determined a safe and evidence-based way to practice it and to monitor it. And so we do that. Now, if I went to a customer in a southeastern rural county with a rural manufacturer and said, hey, I got a great idea for you. How about acupuncture? That's probably not going to be a program that gets adopted right away. So yes, we will maintain flexibility. Interestingly, behavioral health, we used to see spikes of demand in urban areas, the high pressure industries, and we know what they are. I would say today, unequivocally, every single customer in every single location we have, rural, urban, in between, the number one healthcare item on their mind is behavioral health. Mm-hmm. And so part of our advanced primary care model is behavioral health. How can you treat the body without treating the mind? That sounds obvious. But the way we manage to spend, one of the ways we manage to spend $5 trillion every year in this country is that we separate the two. And there's no communication or integration of the two. And so in our health centers, as part of the advanced primary care model, not only are you going to get family medicine, you're going to get behavioral health. We have psychologists, licensed clinical social workers in many of our health centers. And that's one of the fastest growing parts of our business right now.
I would imagine it. And I think everybody in America, especially if they live to a certain age, has a story where that hits home, and for all of us, unfortunately, or but understandably, I think we're lucky to be in Nashville, where so many behavioral health companies have changed the view over the past 2 decades of the social acceptance of that, and brought it up, because I couldn't agree with you more. When something goes wrong, what are usually the things that go wrong, and and how do you deal with them? In this model, so to speak, not just business in general.
Yeah, there is a shortage of primary care physicians, primary care nurse practitioners, and nurses. One of our challenges is, having 100% fill rate across all of our sites. I mean, we have 7,000 employees, and most of them are clinical. And so as fewer and fewer physicians are going into primary care, and the average age of a nurse is far too high, meaning we're not replacing them coming out of school. Fewer and fewer going to nursing school. We have a labor problem. We have a labor shortage in this country for primary care especially. And Premise, of course, is challenged with that. And so that's why we work very hard on culture here. We want to be the employer of choice in healthcare. We want to be the employer of choice here in Nashville, so that, here at corporate, we don't practice medicine, but we support the over 900 sites that do. And so by being an employer of choice, a destination employer, we tend to have our pick of talent. But recruiting and retaining clinical team members is probably our biggest challenge.
Understood and understandable. If I could touch briefly on AI as it relates to that, and what comes to mind, and I don't know if you're employing radiologists directly, but that's a field that I don't think I would walk in today if I were coming out of medical school, just because of the advancements and where it's headed, and we don't quite all know where the world's going to shake out. How are you using or thinking that those tools are going to change your business?
Oh, for sure. Any CEO who says that AI is not going to profoundly change their business, I think is not in touch with reality. We approach it a couple ways. One, we are an Epic shop, so we use the Epic electronic health record here at our company. And Epic, as you know, is a large private business that has maybe the largest research and development budget in its industry. I don't know that to be true, but I've been told that's true. The point is, they spend a lot of money on R&D. And so we expect that Epic is bringing best practice, advanced AI tools to help us as we think about the role of the EHR in our health centers, which is more than just an EHR. It's a hub for point solutions. It is the centerpiece for virtual care. So there's a lot that goes on. And so by being teamed with Epic, we feel like we have a real advantage, because they're going to spend the money. They have the brain power to figure out what is the best AI applications for the clinical EMR. Here at corporate, we're coming off of a 4-year modern, leading edge tech stack build. We have stood up an entire data organization, unlike anything that's in the primary care industry. We have a whole department dedicated to AI. So where are we going to use AI? Well, we have 20 use cases at the moment, but whether it's client reporting, whether it's financial reporting, whether it's looking at trends in how we're having success filling certain positions in certain areas and not so much success in others. So where are these delivery gaps from an operational standpoint that are occurring, and how can we close those gaps? Well, AI is going to help us determine that. So everybody's talking about, we're going to become a data-driven organization. Well, no kidding. If you're not going to have a business much longer. And so we anticipated this. We started spending money 5 years ago on our data org. And my goal by the end of this year is to make sure this company is AI ready. And I would say that 95% of businesses in healthcare are not AI ready. Though Carnival bark that they've got it all figured out, they don't. And so we're taking a very humble, low-key approach here. We're spending money, we're hiring the best talent in the country, and we're going to be ready. But most importantly, we've got the right partners that we think are going to be leading the charge toward what the new world order with AI applications in healthcare will be.
Wonderful. So continuing this future theme that you we're speaking about now, where do you see, let's fast forward 5, 10, 15 years on the employer adoption of this model. Are you that much bigger? Do you have that much more competition? Are there that many more employers under your shelf? How much more scared are the payers of you?
Yeah. You got to dream, right? And so our core business, which is on-site, near-site, and virtual, primary care, occupational health, I never thought we'd be a $2 billion business, but here we are. And there is a ton of runway right now just in our core product TAM, okay? We could double this company if we just doubled utilization within our current health centers. Like, we wouldn't have to sell a new logo to double the size of this company if we doubled the utilization through our health centers. And that is very possible. Not to mention the number of Fortune 1000 companies that haven't been penetrated yet by Premise or its competition. So the white space is really hard to believe, quite frankly. That's in core. But you heard me mention a moment ago, we are getting into the health plan business. What is that TAM? 400 billion? I don't know. How much of that TAM would Premise be able to consume? Well, let's say we can consume just a fraction of it at 20 billion. Okay, that works, especially when you're starting with a base of 2 billion. Now, that's not going to happen overnight. That's not going to happen without us making acquisitions. That's not going to happen without us tying up in partnerships, whether it's with a TPA, member engagement companies. These are the types of assets that we're looking for to round out our health plan offering. But we're getting in the health plan business. The customers are pulling us there. We didn't wake up one morning and say, hey, we love core, but let's go after this. We have been dragged into the health plan business because our customers are fed up with what's going on at Health Plan and PBM Inc. I'm simply reflecting what they're telling me. I'm not giving you my opinion. But this is what the customers are telling us. And so we put our foot in the water about 3 years ago with a customer with this preferred health plan. And lo and behold, we were shocked at two things. One, okay, this is doable. And two, holy cow, look at the outcomes. So we're coming.
Yeah, I believe that wholeheartedly. I look back, my favorite example in history, I know you're a history fan, is the businesses that have ran their own customers out because of their behavior, and think Blockbuster to Netflix, like taxi industry to Uber, or so on and so forth. And they're doing everything they can to drive them to you, and you seem more than prepared to take it. Let me shift a little bit. You have a lot of experience working with private equity firms. And in healthcare, we got a lot of private equity. We're the hottest sector, or largest sector in the U.S. economy, for good or for bad. Can we speak a little bit about how, when you are looking at partners on the equity side, what do you prioritize? What do you validate? How do you underwrite them? Because everybody's got money. Everybody's got people with big degrees and Patagonia vests. So what do you look at and say, you're who I want?
You know, I've been in this business 35 years. I think this is my 9th private capital cycle. I think somewhere like that. That does not include the debt recaps that we've done along the way. You know, Wes, what I would say is that it's hard to differentiate between any of the private equity companies right now. It's really hard. It used to be really easy, quite frankly, 20 years ago. One of the biggest changes I've seen is, you know, in the past, I felt like private equity firms tended to bet the jockey, not the horse. The jockey being the CEO, the team, the passion. The horse being the quantitative underlying metrics of the business, okay? What we have today is in my opinion, very little instinct, very little judgment being applied. It's pure quant. You hear terms like underwriting. Okay, well, everything is it's being subject to the same analysis, and it's black and white. It's a 0 or 1, and it's completely quantitative. And I think that's one of the reasons private equity is having some challenges right now. One, there's too many firms out there. So there's going to be a bit of a washout that occurs, I'm betting. Two, again, they're not differentiatable anymore. I can't tell one from the other. Now, I obviously feel differently about ours. We are owned by a massive pension fund that happens to have a private capital arm, but they're a long holder. So our owner can hold us forever. We're in year 8 right now with them. Typical private equity cycle, as you know, is 4, 5, maybe 6 years. And we're not looking for an exit. So we have a long holder, deep pockets that allows us to make rational and reasonable long-term bets. That is very unique. That does not go on in standard U.S. private equity anymore. My advice to CEOs looking for the right partner, if you're a step-up CEO, meaning first-time CEO, and apparently there are more of those today than ever. I guess there's an exodus of CEOs. That's what I'm told. If you're a step-up CEO, you don't have any choice. You're just gonna accept whoever the existing owner sells to, and whatever management plan that new private equity firm forces on you. You don't have a choice. You're first rodeo. If you're a seasoned multi-cycle CEO, you likely have more of a seat at the table and can influence where the asset ends up. Not always. I mean, there is this fiduciary responsibility, but that doesn't always mean highest price. It can mean highest value. And so I think, again, the multi-cycle CEO has more influence and can be more selective. But again, like you said a moment ago, everybody has capital. So what is it that differentiates one firm from another? You really have to look hard, in my opinion.
Yeah.
And there are good firms out there, but there are too many firms out there.
Yeah, the list grows longer. That's funny that you say that. Absolutely. So if I may push you a little bit again, not the money, is it their ability to grow the business? Is it culture? Is it mentorship? Like what? Give the one or two things.
Yeah, so if you're a step-up CEO, you're looking for mentorship. Mm-hmm. If you're a multi-cycle CEO, you don't want mentorship.
Distance.
You've figured that out at this point. So don't send a psychiatrist in here to tell me what I need to do differently. And I think most multi-cycle CEOs would have that same comment. So yeah, you're looking for cultural fit. You're looking for the Portco family that they bring. Are there synergistic portcos that they also own that would work well with your business model? You really want to take a look at where is the firm looking to go. And so as they're out there looking at new deals, what could be synergistic with the asset that you're running as a CEO? Those are some of the things. There's a lot of discussion around all the different operational benefits they bring.
Well,
rarely do I see the benefit of any of that. It's window dressing.
Yeah. May I ask, if you're a CEO, what do you think the one skill set, if you had to say, is going to be most important for you in working with your sponsors? Mm-hmm. And let me give some examples. A deep accounting background, or a deep finance background, personal financial independence to give you strength to push back. What would you say stands out the most? If somebody's listening and saying, what do I need to get sharper in before I recap?
Rule number 1, perform. If you are not performing, see rule number 1. And so at the end of the day, the only influence and leverage that a CEO or an executive team will have is if they're performing. And what that means is, are you hitting your numbers? Period. You're either hitting your numbers or you're not. And so if you are performing, then the capital partner is more likely to listen around strategic ideas, strategic investment. If you're not performing, they are likely and understandably going to lean in and help you figure out what the right strategic direction is. They say that when you're a CEO, get a dog. It's lonely. And, this is what you sign up for.
Yeah.
You can't walk around the hallway wearing on your sleeve what you're worried about. At the same time, you've got to be human. And so there's this Goldilocks disposition that a CEO has to have that is, it takes a lot of energy. And so last thing you want to do when you go home is talk about work. Mm-hmm. And so you walk your dog. You talk to your dog about it. Well, I took that advice to heart so much so that I got 2 dogs at the same time. I don't think it helped. But my point is simply this. If you're going to sign up as a step-up CEO, if you're going to continue as a multi-cycle CEO, know that it's never a straight line to the finish line. There are going to be some very dark days. And I don't know if you noticed, Wes, but I put a quote up on my glass every week. And this week it says, triumph and disaster are both imposters. You have to recognize that as a leader. You can't get too high and you can't get too low. And I think one of the big mistakes I see with leaders is that they start drinking their own Kool-Aid. They start thinking that they somehow have an edge or an insight or even DNA that's different than others. And that's not the case. And so, once you start believing your own BS, that's the beginning of the end. And I think one thing that this team here at Premise, and we've been together a long time, we're really good at staying grounded in reality, remembering where we came from, remembering how lucky we were to get through some of the tough spots. I think of the great financial crisis. I think of COVID. This team was with me through all of that. It's one thing to be good. It's another thing to be lucky. You need both to get through those. More luck than good, in my opinion. And so my advice is pick your capital partner carefully. Don't believe your own BS and perform. Because you can get everything else right. If you don't perform, you're out. That's what we sign up for. That is the sport that we're playing.
Agreed. And you're right. I've known the Premise executive team for a while, and it is industry leading by a long shot. I want to shift a little bit more on the personal side, and speaking about leadership, what you've talked about there, Premise has taken, and you personally on a philanthropic angle, a hard look towards the veteran population and that employment and that training and that transition. Can you speak about that program that Premise has, how you've built it, secret sauce you've created and where it sits now?
Yeah, I don't know if we have any secret sauce. On the philanthropic side here at Premise, we're one of the largest employers of veterans in the region. There are a number of national awards that we are very honored to have received for being the employer of choice or military friendly, both for veterans and for military spouses. People often ask me, Stu, why is that important to you? Or if you want to really send me through the ceiling, say, Stu, that's so nice of you. Look, this is how we think about veterans and the military community. They're well trained. They show up on time. They understand mission and they understand team. So guess what? That fits here. That's how we roll at Premise. Well, if you check those boxes and you happen to have volunteered to protect our freedom, we want you here if you can do that job. And so right now, a little over 7% of our workforce is military community, mostly veterans, but obviously military spouses in there. We started from zero. And I don't need to remind you, in 2014, Wes, I came to you and said, look, we need to do more with veterans at Premise as an employer. What do you suggest? And you spent a couple days with us. And I don't think we were smart enough to understand everything you told us. That was 12 years ago. And so, we've gone from 0% of maybe 3,000 employees to now 7% of 7,000. And so it's been a long journey. And we've had good advice along the way.
I do remember you were surprised by one thing I said when we spoke about that, and it was they don't know how to network. They think of networking as brown nosing or ass kissing, and they won't do it. And
they don't say I.
Yeah.
They won't say I in an interview.
To take credit.
To take credit. So we had to retrain all of our talent acquisition folks on how to interview veterans because they don't know how to describe their skills a lot of times.
And Yeah, and I mean, you don't know what you don't know. So once you can peer at it through a different lens, it changes things a little bit. May I ask your retention rate from hire to 1 year past?
Yeah.
Do you know that number off the top of your head?
For veterans specifically?
Specifically.
Oh, it's in the 80%.
So when you said you don't think you have a secret sauce, I knew you were respectfully wrong about that, because that turnover rate is way under 50%. That retention rate is way under 50%, meaning
Correct.
the turnover rate is over 50%. So you're doing something right.
Yeah.
And I'm sure that is welcoming and an understanding of that conversation point. So
it creates its own momentum. The more military community members you have in the workforce, it creates its own inertia. And so that's part of it. But we have a talent acquisition function that is very specifically and exclusively focused on military. So military talent acquisition is not just caught up in the general TA effort. It's a very specific focus. We have a fellow, Matt Watkins, who runs our military programs here.
a Marine.
A Marine, yes. He runs as fast as anybody I've ever seen, whether it's an ombudsman, whether it's exit interviews, whether it's advising HR and operations about how to better engage these folks. So we've taken a multi-prong approach, but yeah, you have to commit to it from an infrastructure standpoint. Otherwise, it's just carnival barking. And I hate to say it, but a lot of people, a lot of companies like to talk about their focus on veterans, and it's a great headline. But at the end of the day, it takes a legitimate, real commitment to do it. And we've been at it for 12 years, and I'm not happy with where we are. At 7%, we're proud. 15% is a target. And we're a long way from that. And I thought we would be further than 7% now. But it's a lot harder than I thought it was. That's no fault of what Matt's doing or what our TA group's doing. It's just, it's hard.
Well, thank you for doing it, and wonderful calls.
Well,
I appreciate it, sir. Couple personal questions, and I'll let you go. Favorite band of all time? I know it's ABBA, but you can say something different for the cat.
I don't know. I would say maybe the Foo and the Woo.
The Foo and the Woo.
Yeah, it's hard.
I gotta go to Spotify after this. All right.
It's you can't hate the Foo or the Woo.
Are we saying Foo Fighters and
Foo
Wu-Tang?
Fighters and Wu-Tang.
Okay, all right. I thought there was an actual band called Foo.
No, I mean,
all right. Foo Fighters and
tell
Wu-Tang.
me somebody who doesn't like those two bands. I don't want to be around them.
All right.
Okay.
All right. I'm glad I clarified. I actually thought there was a band called Foo. All right.
You need to get out more.
I do. I'm stuck on my Yanni playlist. Favorite music venue anywhere in Nashville?
Oh,
Both.
sure. Third and Lindsley. I mean,
Third and Lindsley.
That's
awesome.
My wife and I moved here in '96, and so it was one of the first places we went, and it hasn't changed much.
Okay.
Thank goodness.
And that's your favorite anywhere, or just in Nashville?
Just in Nashville.
Okay.
Yeah. My favorite music venue is my backyard.
Oh, all right. Rock and roll. Take that. Unique question. What is one change you would make in any sports league to improve it? I'm going to give you an example. Mine is you can't change out a pitcher in the same more than once in an inning in Major League Baseball.
That's a pretty good one.
Speed it up.
Why is there not a standard ball in golf?
Oh, that's a
Right?
legit one.
We have a standard hockey puck, basketball, baseball, but no, you can use any damn white ball you want to in golf. I don't understand it. Standardize it.
Different pressure, different pieces, different spin. Yeah. That's a good one. That's actually on par with I can't remember his name, the South African pro. He was just speaking at the Masters. He said
Gary Player.
Gary Player saying you should. I thought in the clip I saw he was saying take 60 yards out of the ball instead of making the course longer. Make the ball less compressed.
That would be a corollary to it. Yeah.
Wow, that's a good one. I like that one a lot. All right, sir. This has been exceptional. Thank you for the time.
Enjoy it, Wes.
You're wonderful.
Yep.
Appreciate
All right.
it, sir.
Thank you.
Thank you, everyone.